You can start when you're ready.
Okay. Well, thanks for inviting me to give to discuss. Actually, I don't want to say give a talk, to discuss, because this should be as open a discussion as possible. So this is going to be less as a review of hip preservation, meaning this is not a really a literature review. We're not going to be going through all the literature, systematic reviewing, discussing all the epi, what the outcomes are necessarily as pertains to the literature. We can definitely have discussions as we go through. This is more of a clinical discussion as to how we're working up hip preservation issues in hips in general, from impingement to patients that may have borderline hip dysplasia, as well as those that may be frankly dysplastic. And I sort of organize it in a way that I encourage you guys to ask questions throughout. That's usually the best way to go about doing this. So again, thanks for having me here to discuss. Disclosure statement there. So hip and groin injuries this slide is just here to demonstrate that they're very common injuries. This study demonstrated that between 5 and 9% of all injuries in high school athletes. And here is the nice slide that is out of a study that we published on the hip and groin injuries in the athlete, which basically goes through a not a completely exhaustive list, but a pretty good list of what we're considering anytime we have a patient that comes into the office. Our intra-articular pathology versus extra-articular, as well as non-musculoskeletal. But this is really at the sort of 50,000 foot view of what we're trying to determine. Is this intra or extra articular? And if it's extra, then we go down that path. If we feel it's intra, and we go down that path, and we'll sort of work our way into this as we go through this discussion. Now, this is the sort of layered concept that was put forth by a few guys. One person in particular was Brian Kelly, as another way in which to try to have a systematic or algorithmic approach to diagnosis with regards to these patients, because again, it's a confusing part of the body, and mostly because symptoms do overlap quite a bit with these patients. So layer one is described as the osteochondral layer, and we'll go through these individually here. It's basically it's the anatomy of the hip. The inert layer is the non-dynamic anatomy of the hip. This capsule, labrum, ligamentous complex, ligament teres. We'll get into a few of these in detail, and others we won't really touch on too much. And then we have the contractile layer, followed by the neuromechanical layer. So osteochondral layer is the deep layer of the hip, comprises, again, as we said, the osseous and the chondral structures of the hip. And again, we're trying to determine where the etiology of this patient's pain. Structural pathologies here go into three different groups: either static, which is acetabular dysplasia, which again we'll get into moving forward; version abnormalities of the acetabulum and femur. And I know that version may be something that either if you haven't heard of, if you have heard of, you probably haven't heard much about it, and you may be a bit confused as to how it pertains to hip pathology, and even how to determine and how to measure it. So we'll get into that as well. And then we have dynamic impingement, which is femoroacetabular impingement, FAI, which can be CAM, pincer type, mixed or combined, both CAM and pincer, and then it can also be a subspine impingement as well. And then dynamic instability, if you have borderline hip dysplasia or a hypermobile patient with ligamentous laxity. And then again, these pathologies can affect downstream layers, and you'll see what we mean by that. And that's important because I think that's often missed. And again, doing my training in both arthroscopic and open hip, the open hip side of things, you really were able to identify how the downstream layers are affected. So the inner layer is the labrum, the capsule, and ligament teres. The labrum is around the acetabulum. It's not completely surrounding the acetabulum. It's not 360 degrees, about 270, because you have the transverse acetabular ligament that's inferior in the acetabulum. The joint capsule is extremely important, and we're not going to get into too much of capsular anatomy later on, but suffice to say that today, the vast majority of people are repairing the capsule after every case. So when you go through and you do an intra-articular case, you're going through the capsule, and we're all repairing that capsule. So we don't want to have any laxity as relates to the capsule later on. Ligamentum teres is also a stabilizing structure. That structure is under a lot of research right now as to what to do with it, how important is it. But like anything else, I believe that all of these structures are important. And if we don't know why, we haven't figured it out yet. It's there for a reason. And then as stated earlier, the one layer can affect the downstream layers. Contractile layers, so this is the muscular layer, and it can lead to secondary increases in strains of muscles into layer 3. And then this study here by Casartelli found that decreased maximal voluntary contraction levels in all major muscle groups around the hip joint patients with FAI when compared to control group. So basically, if you had FAI, you had decreased muscle function, and we see that in the glute med as well. So they did studies, or studies have been done where patients had weakness in their abductors and the glute medius, and once you corrected their FAI, their strength in the abductors came back.
Hey, I had a quick question.
Yeah.
Can you talk, and I put it in the chat, can you quickly just touch on the anatomy of the labrum as it pertains to the joint capsule? So it's in relation to the joint capsule.
Yeah, so we'll see that. That's a good question. We'll see that later on. It's not part of the joint capsule, right? So they are two separate entities. And you know, it's a superior aspect of the labrum. When you go in arthroscopically, it is actually, especially when patients have scarring and adhesions, it's actually it takes a bit of time and some finesse to free that capsule up away from the labrum, so then you can work by preserving as much capsule as possible, and then working on the acetabulum superior to the labrum if you're going to place anchors for labral repair, for example. But the labrum and the acetabulum are not congruent, sort of not confluent structures. They are separate. But the capsule clearly is directly on top of the labrum. Once we repair labral lesions, sometimes do labral repairs, we're concerned for adhesions of the capsule down to the labrum, which can then cause pain post-operatively. One item too is to consider is we're going into the iliopsoas. So the iliopsoas has been described as being a potential impingement contributor. So it comes over the anterior aspect of the acetabulum, and that can, if it's tight enough and under dynamic circumstances, it's been described that can actually cause lesions to the labrum in that region where the iliopsoas comes over, just on direct force of the iliopsoas tendon on that anterior aspect of the labrum. So the iliopsoas, it's a origins and insertion. The iliopsoas is the only periarticular muscle that can contribute to stability moving the trunk. So it's very important for stability. This study by Fabricant we put in here demonstrated inferior clinical outcomes of patients undergoing a psoas tendon lengthening. So basically, that scenario that I just described, where you might go in, you might see a lesion on the anterior acetabular labrum. Some have thoughts that it's due to the iliopsoas, so therefore we should release or lengthen the iliopsoas. Well, we found that you contribute to instability when you do that, especially in patients that are ligamentously lax and in patients that might have borderline hip dysplasia. So the vast majority of lengthenings or releases that are happening now tend to be in patients who are post-total hip arthroplasty that are having some iliopsoas issues. But in a patient, especially one that's borderline dysplastic or a female that's ligamentously lax, the iliopsoas lengthening or tenotomy will almost definitely lead to increased instability. So we're not doing that anymore. And it was described and done more commonly previously. Just back to anatomy very quickly. So you have the psoas and the iliac has become the iliopsoas. It comes over the superior pubic ramus, and the pectineal eminence is here. And when you have, can you see my cursor? Yeah, so pectineal eminence is here. And so when you have the internal snapping hip, this tends to be where it is. And then it comes down and it attaches to the lesser trochanter. So this is the region right here where I say that you can get these labral lesions that people believe with regards to compression of the iliopsoas. Ilocapsularis, you may have never heard of. So this is a muscle that goes over the anterior aspect of the joint. As the contraction of this muscle tightens the hip capsule and subsequently imparts the relative stability to the hip joint. Ward did a study and found that the iliocapsularis is more prominent in dysplastic hips. Now, why is that? Well, because, and we also found labral hypertrophy increases with dysplastic hips, and it's because there's more micro instability, more motion there, and the surrounding structures are working harder to maintain the congruity of that femoral head within the acetabulum. Therefore, you get hypertrophy of both the iliocapsularis as well as the labrum in that region. Does that make sense? And so this is, I thought was a nice views of the iliocapsularis. So it's the iliocapsularis is right directly on top of the capsule, and so is the gluteus minimus. And so when we go through arthroscopically, these are the muscles that are there superficial to our capsule. And when we go and we make a cut to get in here, we make a transverse cut across here. And then some people do a T capsulation, which is another limb, and another cut right through here. And you end up trying to go between your iliocapsularis, which is in green here, and your gluteus minimus, which is in yellow here. This would be your cut arthroscopically to get in there, the sort of T limb. But the point is that the iliocapsularis does come right over the anterior aspect of the capsule, and then the gluteus minimus is directly over the capsule. So when you do an open procedure and you try to get to this capsule, especially if you're doing a surgical hip dislocation, you have to actually tease off all this musculature because it is firmly adheres to the capsule superficially. In the iliocapsularis, we are studying because I believe that it is a very important muscle. There's some MRI literature too that has demonstrated the hypertrophy of the iliocapsularis in patients with instability, because again, it is acting. There's more strain and stress on the iliocapsularis with that head, the instability of the femoral head, that the iliocapsularis is working harder to maintain the congruity and keep it located within the acetabulum. Any questions about iliocapsularis and that anatomy there? So moving on to the contractile layer, and this is I thought was a nice slide just to show the origins and what we're discussing, because it can get quite confusing. This is our ASIS right here. This is our AIIS, right? Our inferior iliac spine. So you have the direct head of the rectus is here, and just underneath that is your iliocapsularis origin right here. And so then your capsule is right in through here, the hip joint capsule. And then we have the direct head of the rectus femoris, and then we have the indirect head of the rectus femoris that comes across. And I have another slide that will show that later. But basically, the rectus comes across, and then the indirect head comes over, and it attaches, in that sort of 11 to 1-ish region of the acetabulum. 12 o'clock would be the stellate crease right here. This would be 12. And so I believe also that the indirect head of the rectus femoris is acting to help stabilize the hip joint. But it's similar to the biceps tendon in the shoulder. There's or even less so data to that, even looking at that indirect head. And so we're also looking at that in dynamic ultrasound studies right now. So the neurokinetic layer is the other layer. This is comprised of the thoracolumbar plexus, the lumbopelvic tissue, and lower extremity structures. So this is sort of the layered concept of the hip and how to think about the hip. Any questions about that? Discussions? So now once we're still thinking intra versus extra-articular, the next sort of process that we go through is this an impingement process, which is an intra-articular process that can also have extra-articular manifestations, as we just said. You can have pain, you can have muscle weakness caused by impingement, versus instability. Does the patient have frank dysplasia under coverage, or are they borderline dysplastic with a hypermobile component that is causing instability and pain? Again, instability can cause pain intra-articular as well as extra-articular. So impingement is when people describe impingement, femoroacetabular impingement, you have pincer impingement, which is from the acetabular side. This is over coverage is the best way to put it. We'll get we'll move forward into imaging, but don't think of retroversion automatically as being a pincer. Don't think of coxa profunda and protrusio as being pincers. You can have protrusio profunda with under coverage. You can have acetabular retroversion that is not pincer, because if you go in there and you shave that pincer and you have a really retroverted acetabulum with a insufficient posterior wall, now you've just created global laxity, and the patient will not do well. If that makes some sense. And again, ask questions, because I know some of this is, you don't get that often. So some of the anatomy and some of the things I'm saying might not be that familiar.
What's the I guess, is there a increased likelihood for either one of these for bilateral presentation, like in people, for either cam or pincer?
So the vast majority of impingement that we see is cam type. And so cam is the osseous bump that you see here on the femoral head neck junction. And we'll go through the location. It's typically anterolateral is the typical presentation of it. And what you end up seeing, and again, I have a few slides down. We have more literature now that has been coming out that suggests that the cam morphology is forming in adolescence during the growth spurt. And so when the growth plates are open, we are actually seeing, or when the growth plates are closing, rather, we are seeing this epiphyseal extension. So the physis is actually extending laterally and anterolaterally, and then you're getting this cam development. People will have it bilaterally. And then I also have a slide on the epi of asymptomatic cams that we can go through as well. But cam is by far the most common. Pincer less common. Pincer was also, if you saw profunda protrusio, which we'll get through the imaging, what exactly defines profunda protrusio, but I only mention it because every time, historically, if profunda and protrusio were seen, or retroverted acetabulum was seen, it was automatically being coined a pincer. And we have learned more, and that is not the case. You also have a combined impingement. You have cam and pincer impingement. Pincer is more common in females. Cam is more common in males, historically speaking, from the data. However, we are seeing more cams, so that means more cams in everybody. Females are coming in with cams as well. And then an impingement that is not talked about often, that should be, is the one way to the right. That is subspine impingement. That is where your AIIS is prominent. There's a classification system, 1 through 3, depending on how prominent overhanging the acetabulum it is, but it's just nice to be aware of subspine impingement. You can have pain with direct flexion with subspine impingement.
Hey, Dr. Regine, it's Dr. Shang-Rich. I guess for some of the viewers on the call, are we going over a little bit on some basic overview of the hip version as well?
Yes.
Awesome. Thank you.
Yeah, definitely. We'll do both femoral and acetabular. Try to organize it in a way we get into this, and then we'll go into our exam. We'll go into our imaging. Again, trying to do it as a clinical setup and how we're going to think about these. So this is the cam morphology that you see here, and this is nice because I thought it was, the color coded makes it easier to understand. Here you have the pink. These are your normal hips, your idiopathic cam lesions that are in the yellow. And I don't know if you can appreciate, but you see here, this would be the physis, right? So in the pink would be the epiphysis. Okay, see the cam lesions. See how this extends over here? So this is the lateral of the hip. So see how this extends here anteriorly here. So that's your epiphyseal extension right there, and that's your cam. And then this is the anterior aspect of the hip on your AP that's extending it, and that's it. That's your cam right there. A slip-like morphology or a post-slip morphology. This is SCFE, slipped capital femoral epiphysis, that happens, in skeletally immature patients where the head actually slips, the epiphysis actually slips in relation to the femoral neck. And then these patients, if they're missed, these post-slip SCFEs will present later in life like cams, but it's not a cam that was formed in the way that I was describing. If you're an athlete and you have epiphyseal extension, this isn't actually a process where the patient had a slipped capital femoral epiphysis that we'll see later in life, presenting with cam type impingement symptoms. It's a smaller group of patients, fortunately, but that's what we'll see. So this is the clock face when we're looking at the femoral head, femoral neck, and so this is going to be anterior here. and this will be posterior over here. And the vast majority of your cam lesions are between 12 and 3 o'clock. So they're right here, anterolateral. So that's where the cam lesions are. Now, anatomically speaking, that's maybe fortuitous for us because the vessels come up right in through here posteriorly, and that are the vessels to the femoral head and neck. And so for the vast majority of times when we're addressing cam lesions, it's going to be anterolateral and we don't have to worry about the vessels there. Now, if you have a posterior cams, which we're not going to get into much in this or much at all in this discussion because they're much less common. And so I don't want to go too, in depth with things that are less common. Those ones may be challenging to get to arthroscopically, and you may have to do a surgical hip dislocation to get to some of those posterior cam lesions. So this is a sagittal view of the pelvis with femoral head and the femur subtracted, right? So we're just getting an en face view of the acetabulum. This is a great way to look at it. Again, we went through this anatomy and these origins, direct head, the iliocapsularis, the indirect head, the capsule over here, and then the labrum here. So the acetabulum, I said, this is the acetabulum here, and right over here, this gap here, well, that's where your transverse acetabular ligament is. So this is why I said the labrum goes about 270. It's not 360, right around here. Iliopsoas U, well, this is where that iliopsoas is coming in, and there's literally a little indent in a U that's formed about this sort of 5-6 o'clock, you can say 4 to 6 position right in through here. And that's iliopsoas U. The stellate crease defines the superior aspect of it. And again, the majority of our cam lesions are right in through here. Therefore, the majority of our pathology is going to be in this region and maybe back a little bit towards 10 o'clock when we're getting labral pathology within the acetabulum. And then you can see here, they put the direct head of the rectus and the indirect head of the rectus right in here coming over the top. And to your point that you were talking about earlier, Miriam, and we're going to see some videos and pictures of that later. We get underneath that when we're scoping. So we're inside, but then we still have to elevate some of that up and separate and find our space between the labrum and the capsule there.
So I was asking for our purposes too, for when we're used to doing the intra-articular hip injections under ultrasound.
Yeah.
Easy, straightforward, especially when we're just doing a block, a steroid intra-articular hip. But when we're doing PRP for the labrum, would we change our target? So our target would be head neck junction.
Intra-articular.
Doing intra-articular, right? On ultrasound.
Yeah.
So for labrum, is there a more ideal target for us if that's what we're targeting, PRP, or would we do that same intra-articular approach?
No, intra-articular, because that's where the labrum lives, right? And so it's intra-articular. So I liken it to the knee almost. When we do injections for the knee, sometimes we'll do the anterolateral portal, we'll do the anteromedial portal, we'll do the superior lateral portal, when the leg's straight, we'll inject there if we aspirate the knee. And it's all, once you're in the capsule, you're in the knee, you're intra-articular, and then whatever you've injected, cortico, visco, PRP, it's going to bathe the intra-articular aspects of the knee and all the structures that are there. So once you're intra-articular and you're through and you're deep to that capsule, Miriam, then you're in, and whatever you've injected, the labrum, the acetabulum, all of that is going to be exposed to what you've injected. We're not injecting the labrum directly or into the labrum or anything like that. Yeah.
Right. I've heard so many different things from surgeons as to where the labrum actually lives. So,
well, and obviously I can't speak to that, but I can say there is no variation as to where the labrum is in anatomy. Right? It lives in one place, which is exactly where we did, and it's on the rim of the acetabulum. Certainly intra-articular. And this is now, are there lesions there? Yes or no, but there's no variant in that sense. Now, of course, you can have an everted labrum, invert, all these things, but the anatomic site of the labrum is consistent. And so if you're going to do an injection in the hip, and we're really not injecting necessarily for labrum, even though they might have an anterolabral tear, you know what I'm saying? It's for pain and pain relief. But once you get inside the capsule, you're all set with that injection.
Thank you.
Yeah, sure. Jasmine.
Okay.
No, go ahead.
Oh, yeah, it's Rich. So in terms of, I guess, some of the ultrasound studies, they do inject some of the PRP injected, I would say, into the labrum, into the label that's pathologic, and obviously some of the head neck junction. I know in one group in NRH in northwestern Chicago, they looks like they just injected into the pathology. So I don't know if your thoughts about that. And it looks like it was positive results, but it was on the end of 8.
Yeah, so I don't think you can glean any. I don't think we can gather really not any, but much important information from those from case series. We can certainly, use that data to inform larger studies. But I do a lot of statistical fragility analysis research, and I would say that is going to be a fragility factor of 1, where if I change one of those patients' outcomes, you're going to have a non-statistical significant outcome and result. And so we don't inject the labrum either if we're going and we are during the case, for example. So if we're doing cartilage preservation, or if you're doing a labral reconstruction, we're even surgically not injecting the labrum directly. Now, there is some data coming out and some research coming out on ACLs where people are injecting PRP or BMAC directly into the allograft ACL if they're doing an allograft ACL reconstruction. But that is one study that is coming out or just came out. And so it's very minimal, and that's in the knee. And there's really nothing like that as far as the labrum is concerned in the hip about injecting it directly with orthobiologics. Not to say it can't help in the future, but I don't think we can make any clinical decisions on an N of 8 other than allow that to inform a hopeful N of 1,000 and see what they. So here's your prevalence of FAI, an asymptomatic volunteer systematic review by the team out of Rush. And so go down to the results section there, kind of get through it a bit. Second sentence, the mean participant age was 25 years old. Mean alpha angle is 54. So we usually alpha angle of roughly 55. It's an argument of 60s and 62 and things like that. Roughly 55. Anything less is non-cam. And anything greater is CAM, and that's from these studies that we find that majority of patients are symptomatic if they have CAMs greater than 55. And so the prevalence of an asymptomatic CAM deformity was 37% to 55% in athletes. So there's many athletes out there who have CAMs that are asymptomatic, and the general population was 23%, right? So the general population, 1 in 4, has asymptomatic CAM, and it's more prevalent in athletes. So there's many out there. So this is when you discuss with your patients, you might have the CAM morphology, you might have a labral tear, but many people like a meniscus tear have it and they're asymptomatic. And so just because we've discovered this on MRI, we're going to go through in an exam and we're going to find out, where your pain is, because this may be a bit of a red herring, and please don't focus too much on your labral tear until we actually just decide whether this is actually the etiology of your pain or not. Make sense? So this is the beginning of my exam. That's what I have in my sheet, and I also have a separate work one in school. So I just want to see what their activity level is and what they have done previously. But then I go through a Baton score. I do a Baton, I do a gait. Do they have a limp, not a limp, and what's their foot progression angle? Is it internal? Is it neutral? Is it external? And I think it can be very helpful in helping to inform these version things. Although we do know, Richard, that it's not entirely accurate to assess version with regards to your foot progression, but I think it's informative, and then palpation here. And so Baton score for just a refresher, you get to out of 9 scores, so it's bilateral for 1 through 4 here, and then 5 is the 1 point that gets you to 9. And this is your Baton. Many people will consider a Baton of 4 or over as being ligamentally lax, although this is also a debated cutoff point. Dynamic examination. So IR FPA test, right? So the internal rotation, foot progression angle walking test, right? So this is described by Ranawat out of HSS. So, and I like this test. So you have the patient walk, and you have them walk pigeon-toed, turn their foot in, and you have them walk. Internal rotation, foot progression angle walking test, and this can create symptoms because when you're internally rotated, you're putting pressure. That CAM is putting pressure on that labrum, and then you do the external foot progression walking test, and this might give you a suggestion of instability if they have pain anteriorly with this. I do a neutral squat, See if that causes pain. This would be for superior impingement of the AIIS. Internal squat would lead to anterior impingement if they have groin pain with this, and then an external squat might suggest instability. So these are other dynamic exams that you can go through, and then Trendelenburg, everyone's familiar with. Resisted sit-up, we check that because they're always supine, and why not? So you're looking for athletic pubalgia. Straight leg raise, of course, abduction, range of motion. Once I have them abducted out there, then I just simply say scissor back in against my resistance, and that's my adduction. Resisted adduction, just to check their adductors to see if that might be their pathology well. Flexion range of motion I'm looking at. I'm also looking at flexion pain, right? So I flex them straight up. They have pain straight up. It could still be FAI as far as CAM is concerned, but it also could be a subspine impingement if they have direct flexion pain. Flexion internal rotation, I want to get their range of motion, and external rotation. That's going to start informing me about version, as Richard was talking about. So if I have increased internal rotation and flexion, it might suggest anteversion. Increased external rotation and flexion would suggest retroversion. Now, if I have a retroverted femur, those impinge more anteriorly. If I have an anteverted femur, those can impinge posteriorly. And then anteverted femurs can lead to ischiofemoral impingement, which is posterior-based structures of impingement. And we'll go through the version stuff later, so hopefully that makes more sense. But these exam maneuvers are vital because they're helping to inform what's going on with the anatomy here and how these patients may be impinging. And then I go through abductor strengths. I think that's all I wanted to say about that. And then here's your impingement and instability testing, specific sort of special tests, right? So flexion pain, fader flexion, adduction, internal rotation. So you flex them up, then you adduct them a bit, and then you internally rotate them. If they have decreased internal rotation, that could be because they have retroversion, or it could be because they have a CAM. And so CAM is going to decrease your internal rotation in flexion and adduction. And so, and this will cause pain. So FAI leads to pain with fader. All these impingements that I have here in print, anterior impingement, this is FAI. DIRIT is dynamic internal rotatory instability testing. What is that? It's like a grind test. You get them up in flexion, and you just circumduct internally. So from neutral, not external, but from neutral, and then you just flexion extension, and you're just going internal like this and adducting them at the same time. It's dynamic internal rotatory impingement testing. If they have FAI from a CAM or pincer, this should recreate their pain in a labral tear. If none of this recreates their pain and they have a labral tear on imaging, it's very likely not the labrum or their CAM that's causing them pain. And ABIR, so that's abduction internal rotation. So basically just straight abduction internally rotated, and that's sort of like a lateral CAM. They're engaging the lateral CAM. And then a flexion abduction internal rotation. So I abduct them, flex them to 45, and then internally rotate when they're about 20 abducted. If that makes sense. And that engages the lateral CAM. So that just helps to inform the extent of what their CAM might be. Is it just anterior lateral? Is this lateral? And then we'll go to imaging, right? But we're trying to gather data by exam. Faber, flexion abduction external rotation, or the Patrick test you may have heard of. So this is if you have anterior symptoms, you have to ask them when they do these things, where does it hurt? If it's anterior, this could be instability. If it's posterior, okay, then this could be a posterior impingement, ischiofemoral impingement, some sort of posterior process. When I do fader, sometimes I do flexion, adduction, internal rotation, they say they have pain. And I say, okay, where? Right over the abductors, because sometimes you're stretching those abductors. So don't just do your fader and they say, oh, ow, or they have pain. And okay, you have an impingement. No, they might actually have pain in their abductors because you're stressing the abductors. And that happens often during that test. So just try to ask them where that pain. Dextrate is dynamic external rotatory impingement. It's the same thing as the internal. You're coming up, but you're doing an external and grinding them out externally. And then the ab here, this is abduction, hyperextension, external rotation. Get them at the edge of the table on the side. You abduct them, extend the leg, and externally rotate it. And that is an instability apprehension test for the hip. And that's placing pressure on the anterior aspect of the hip. So if they have pain in the groin with that, it's giving you a hint of instability for anterior symptoms. And again, posterior symptoms would be something in the back, like an ischiofemoral impingement. I know this is a lot of tests. Any questions? It's quick. Once you get this down, you can fly through these tests. So here's fader, flexion, adduction, internal rotation. This is the one that you've been tested on, and this is the most common one that you'll see. And this is your most common anterior impingement test right here. But again, ask where the pain is because it could be in the abductors. Many patients will have that. Faber. In this position as well, I will put my hand down the ASIS to stabilize the pelvis. In this position, I will also palpate because they're right there. I will palpate the rectus. I will palpate the iliopsoas, just medial to that, to the rectus. And then I will palpate along the superior pubic ramus. So you have the pectineus and you have the adductor longus, you have the gracilis that are all attaching right through there. Then patients can be exquisitely tender right along there. Now, if they are, go to the contralateral pubic ramus because this is not a fun place to be palpated, right? And so it can cause just symptoms in general. And depending on who the patient is, they may just say that they're tender, and you go to the other side and they go, okay, no, that's the same. Makes sense. But this is a good position to do that sort of exam. Anterior apprehension test, you can do it this way as well. So you've had to come to the edge of the table. I usually have them come to the edge of the table, abduct them out because it's easier. This one is it takes a little bit more time for them to actually get themselves at the edge, figure out how far off the edge of the bed they need to get. But this is basically trying to elicit anterior base pain. You're going to hyperextend the leg, and then you're going to externally rotate it. And this is an apprehension test, test for instability, anterior instability of the hip. Hip prone instability testing. So you put them prone, and prone is the best way to assess the internal and external rotation, whether you have version concerns. And then this has also been described where you're going to externally rotate them, and then you're going to pushing down in the greater trochanter. This has been described by Ben Dome as a good test. Not everybody uses this test, but this is another instability examination maneuver. And then now we go to imaging. So this is everything for imaging. Now, do I measure this every single time? No, but I'm looking at it and I'm thinking about it every single time. But if I'm taking the patient to the OR, I'm going to have all this data when I go to the operating room. AP pelvis. So we don't get them supine, I get them standing, but this is how you would get an AP pelvis. And you get a 15-degree internal rotation to address the version, because you want to get the long axis of the neck of the femur. So you get a 15-degree internal rotation. Perfect AP, and this is important, right? Because you're looking at all of these different things on your anatomy and your angles here. You want about 1 to 3 centimeters from the superior pubic ramus, or the pubic symphysis, to your coccyx. If you don't, you might have an inlet or an outlet, and that crossover sign on the acetabulum may actually not be there. And so you really need a perfect AP. As you see the obturator frame in there, you don't want them to be huge circles. They're more oval shaped when you're in a sort of perfect AP. And again, this is important. This is why we harp on some of our imaging, because we're trying to determine things by imaging, and you can't determine anything unless your imaging up front is actually as accurate as it should be. Okay. And so, I work with my guys here all the time, and I go over there and sort of say, look, this is what I'm looking for. And then I explain why. And so we get there to get perfect imaging. So tonus grade. So use Kellgren-Lawrence for osteoarthritis and joint space narrowing in the knee. Use tonus for the hip. And here it is. So you get grade 0, you get grade 1, which is mild thinning of the joint space. Grade 2 is increased thinning, but basically it's when you see some subchondral cysts. So and how to get subchondral cysts? It's because you have some cartilage damage. If cartilage damage, so you have increased point loading in that region, and that leads to the cystic formation. And then grade 3 is increased cysts. We will do a hip arthroscopy, definitely grades 0 and 1. We debate on grade 2 because outcomes don't seem to be as great on grade 2 to do a hip preserving procedure for, like a hip arthroscopy. We certainly don't operate with hip arthroscopy, do any hip preservation for grade 3. And many people won't for grade 2. This is also, we measure the joint space at the source seal. So the weight-bearing dome is a source seal. It's that more dense bone that you see at the top of the acetabulum here. That's the source seal. It's a weight-bearing dome right into the air, because over here, this is the cotyloid fossa. There is no cartilage here. This is the cotyloid fossa. And so there's no cartilage in this region of the acetabulum here. This is the weight-bearing dome. And so we measure this. Why do we measure this? Because there's data that shows that less than 3 millimeters of joint space leads to slightly inferior outcomes from a hip preservation procedure, meaning their osteoarthritic process and their chondral malation and chondral damage is a little bit too severe to have a great outcome for arthroscopic management. Joint congruity, Yasunaga, is the
Dr. Parisian, am I
Yes.
saying your name right? Sorry,
Parisian, yeah.
Parisian. This is Lissa.
That's the American way, the French way is Parisien, but you know.
Yeah. Just going back to the last slide. Thank you. So you said there's a weight-bearing dome, and then I guess medial to that, there's a space where there's no, what did you say, cartilage? So when I'm reviewing an X-ray, if I'm going to interpret for the patient, should I be focusing on that weight-bearing when I'm giving my opinion of or should I be looking at the whole space where the femur is articulating?
I look at the whole space, but to answer your question, no, the weight-bearing dome. This is where you're going to determine tonus grade. This is where you're going to determine degree of bursitis is the weight-bearing dome. See this little notch right here, this fovea. This is where your teres. This is where your ligament teres is. That's not in the head. Your ligament teres comes out of here, and it goes like this, and it comes down and it attaches down here into the region of the transverse acetabular ligament. This teardrop, right, that you guys see here, right? Are we familiar with the teardrop? So this is described as a radiographic teardrop. This thing here, this little sclerosis in the bone. This is made up of the cartilage fossa, which is right here, which is the central portion of the acetabulum that doesn't have, and it's the quadrilateral surface of the inner table of the pelvis. And so basically, if I'm coming down, this is the pelvic brim. If I'm going to open this pelvis, I'm doing an open procedure. I'm going to come down over the top. I'm going to come down. There's a quadrilateral surface here. That quadrilateral surface is right here. And then the cartilage fossa is right here. And the cartilage fossa, we'll get into it, will help us determine protrusio. So this patient would have slight protrusio. That cartilage fossa is just medial to the quadrilateral surface right here. Now, I look at this because if I have more than 1 centimeter of gapping between my teardrop and my medial aspect of my femoral head, then I'm concerned for instability. More than 1 centimeter of space here. But like I said, to keep things, not get too particular with things here, when you're assessing it and you're discussing with your patients, as you said, you're going to look and measure the space at the underneath the sourceal, the weight-bearing dome. That's where we determine our tonus. You're not going to get joint space narrowing over here unless you're tonus 3 and you have bad arthritis.
Okay, thank you.
And that's why this is helpful. Joint congruity. So you see, this is all weight-bearing dome. So in addition to tonus, so this would be like a tonus grade 3, right? Tonus grade 2. And when you look for joint congruity, and it's in relation to the weight-bearing dome. It's a great question. So this is what I was talking about before. So this is a normal teardrop here. You have the cartilage fossa here. You have your quadrilateral plate right here, quadrilateral surface right in through here. And we also call this the iliopectineal line that comes here. Ilioischial line comes down here into the ischium. And then profunda, this medial aspect of the acetabulum is medial to the ischiofemoral line or the quadrilateral surface, however you want to think about it. But this is the definition of profunda. Protrusio is the head. The head is medial to the quadrilateral plate or the ischial line. Does that make sense? So protrusio and profunda were described, and when people used to, in the past, historically said protrusio or profunda, they would automatically equate it to pincer. That was like, one of the terms they would use almost for pincer, but we do know you can have protrusio or profunda without a deep socket, without pincer. So that's what I'm saying. Don't equate the two. You can have one without the other. Those are the definitions of profunda and protrusio. So crossover signs. So we're looking at on AP pelvis. So I'm going through, these are all the things that we're looking at just on AP pelvis. So we can spend a lot of time just on imaging, but the red line is outlining the posterior acetabular wall, and the yellow line is outlining the anterior acetabular wall. And so the anterior acetabular wall should not cross the posterior acetabular wall. And so the one on our right looking at this is normal, and the one on our left is abnormal. So that would call that a cranial crossover. So it's crossing over high. So you can have crossovers in the mid portion, or you can have caudal crossovers that are even lower. Now, but this is giving us some sort of sense of, is this a retroverted acetabulum if you have a crossover sign? There's other things that we look at as well, and we'll get into those, because we don't just say, okay, this crossover, therefore it's retroverted. So that's another, it's just one piece of information, one data point. So there's another slide, and I'm sorry it's a little blurry, but this is our crossover here. So we're saying, okay, the anterior acetabulum actually crosses over with the posterior acetabulum. Maybe it's retroverted. So normally the acetabulum is anteverted. It points forward about 20 degrees. It's opened up forward to the anterior aspect of the patient. So, but if it's retroverted, it's maybe shifting a little bit, turned a little bit back posteriorly. We also look for the ischial spine sign. Is it a prominent ischial spine as compared to the other side? That is another clue that this could be a retroverted acetabulum. And then we have a posterior wall sign. Sorry, it's blurry here. See this dot right here? This dot is saying that this is the center of the femoral head. If that center of the femoral head is lateral to the posterior wall, that means that this is a posterior wall sign. This is telling us that, again, this acetabulum may be retroverted. Okay, so we take all these things into account to see if we have a retroverted acetabulum just on AP radiographs. Because in normal hips, this center point is not lateral to the posterior wall. And then we can do anterior and posterior wall indices. I won't get into those, but it's another measure.
I have one more question. This is Lissa again. Why is the ischial spine in this case? Why is that an indication?
So you can imagine, I'm trying to use my hand here. So
yeah.
If it's, I don't know if I can do that, but if it's opened up towards us, that acetabulum, and then if you turn it a little bit, the ischial spine is part of the pelvis there. And so the ischial spine also comes out, if that turns back, the ischial spine is going to come up and present itself more in the AP. And so you have a more prominent ischial spine.
Is rotating.
Exactly right.
I think the retroversion of the acetabulum as it being rotated, for lack of better explanation. So and we always look for asymmetry, right? So the first thing you want to do is what Dr. Parisian said, make sure you have a true AP. Mm-hmm. And then you're going to look for an asymmetry and say, why is that ischial spine protruding more? So it must be some sort of anatomical rotation showing it. And I think it's really quick for us clinically why all that's important to look at an x-ray, because no one reads that. Like radiologists won't read that for you, and you'll go in and do it. And I always thought okay, we're getting these x-rays on people that we're saying it's either FAI or labrum. It's an intra-articular pathology. We want to look at it, like younger patients versus OA in our older ones. And one thing that a surgeon once said to me when I was just like, oh, it's a person with a labral tear. And they're like, why? And I'm like, I don't know, they're a runner. And they're like, not everyone that runs gets labral tears. Why? Why do they have the labral tear? Because if we don't know why and we don't fix it, whether through rehab or surgery, they'll re-tear it. There's no need to fix it surgically because it won't do much. So I think, and that's what made me start looking at these things and be like, well, the why is they have a retroverted pelvis, they have retroversion, and that's what's causing or caused the labral pathology or made them more prone to it. So I just wanted to point that out to our group, because that's what makes this super, super important for us. I couldn't answer that why when I was asked by a surgeon. I had no clue. I'm like, I don't know.
You want to do exactly.
It's the labrum, just do what I tell you. But now
right. The why is vital. And unfortunately, it's because you're not going to fix something when you can almost predictably know it's going to happen again, right? And there's no point. So that's why with the labral, like the regular CAM type FAI, for example, we're going to go in and fix the labrum. But we're also going to do a femoroplasty. We're going to shave that bump away, so it doesn't. So if you fix labrum but you don't take the cam away, it's going to engage labrum again. It's going to re-tear. So you have to know exactly what caused that pathology. So now we're looking at lateral centroid angle. Lateral centroid angle of Weiberg is
Dr. Parisian, you're frozen. If you could hear us.
Am I back?
You're good. You're back.
We're back.
All right. So lateral centroid angle is going to see if we have dysplasia versus over coverage versus a normal acetabulum. And this is looking only at the lateral acetabulum. And so anything less than 25 is going to be consideration of maybe a borderline dysplasia. Less than 18 is going to be This would be frankly dysplastic, greater than 40 would suggest a pincer over coverage. This is just the lateral acetabulum. This is another way of looking at it here. Normal in the middle, deep acetabulum or pincer would be on the right here, maybe greater than 40 angle of lateral centerage angle, and then dysplastic on the right, less than say 20 or 18. This is the tonus angle. Tonus angle is looking at the sourceal, the weight-bearing dome, what the angle of that weight-bearing dome is to tell you what the coverage is. And so that angle should be 0 to 10, but we pretty much say that under 15, it's in the normal-ish range. 10 to 15 might be a borderline dysplasia, but over 15, meaning if that angle is like this on this one, then you might then that speaks to dysplasia. Does that make sense? Fear index. So this is another one. We look at the femoral epiphyseal acetabular sort of ratio here. But so the inferior line, that white line, that is the physis. That line is going along the physis. Weight bearing is going to go through the perpendicular to the physis. Okay, so if this, if you can think of it as this white line and the physis is horizontal, that means that the weight bearing has not going into the hip, it's been going straight up. Does that make sense? And that can happen for several reasons. You can have a valgus neck angle, and that's another thing that we look at. We're not going to get into too much here. But you can have a valgus neck angle, so your weight bearing is going straight up. You can have dysplasia under coverage, and so with under coverage, your weight bearing dome is going to go straight up, and the physis is going to form perpendicular to the force, to the weight that's being placed on it. And so this is another angle. So basically with the fear, the way to look at the fear is you're looking at the line on the sourceal, the acetabulum, the medial and lateral aspect of it, as it relates to a line, tangential to the longest aspect of the physis. If you converge laterally, you probably have appropriate coverage. If you diverge laterally, it speaks to dysplasia. And again, you could have a valgus neck angle too. A 45-degree done lateral, this helps us look at our cam morphologies, and this is how we get that view. And this is what we get and what we're able to assess. So we do an alpha angle, and what you're used to the alpha angle, it's an asphericity of the femoral head. Where does it become aspherical? And this is how you measure it. And we use 55 degrees roughly. But again, everything is not cut and dry on one cutoff, but we roughly use 55 degrees. But this is the alpha angle on how you get it. 45-degree done lateral, and that will give you, so that your AP will give you about the 12 o'clock cam. Your done lateral will give you roughly 1 to 2, and then 2 to 3 you'll get, oh, sorry, you can see a subchromal impingement cysts here as well. And then 2 to 3 you'll get.
Rob, sorry. Oh yeah, okay. No, I was gonna say, would you take that cross table lateral or frog leg lateral when measuring alpha?
I usually go with the frog leg. Yeah, as you go to frog leg. So we know that again, it's what we're trying to look at, right? So for a 12 degree, we're going to get in the AP if they have a massive cam, and if I have a laterally based impingement signs on exam, that abduction, internal rotation, flexion, abduction, internal rotation, and then I see a cam on AP, then I know they got a cam laterally or superiorly based, right? The 45-degree done, and these have been done. These studies have been done by the group that I trained under at Boston Children's Hospital, and so we know that 45-degree done is then they're going to give us our 1 to 2. And so we're now going more anterolateral. And then now if you go to our lateral frog leg like this, it's going to give us 2 to 3 o'clock. And that's really where our lesions are. And so we've covered our bases on those 3 views there. And we know where our cam, where it is. And I'm going to repeat these views in the OR too. I'm repeating all these views in the OR. You're going to do the femoroplasty, and then you're going to go back and repeat the views and make sure that you don't see the cam anymore in these locations that you saw preoperatively. And here's a head neck off. Go ahead, sorry.
I said thank you.
Oh yeah. And then here's head neck offset. So head neck offset is another examination that we, or another thing that we evaluate. And so suffice to say, if you have decreased head neck offset, less than 0.17 is the actual number that we use, but that means that you have asphericity of that femoral head if you have decreased head neck offset. And so you may hear people discussing that as well. This is a false profile view. You won't see this very often, but in every patient that you evaluate for cam, every single one should be getting this view. And the false profile view looks at the anterior acetabulum, and they're angled like this, 65 degrees. And it looks at the anterior acetabulum, And it allows us to look at the anterior center edge angle. It's just like the lateral center edge angle, but what's their anterior coverage like? And for anterior coverage, their normal is greater than 20 and less than 20 is going to be consideration of dysplastic. So this allows you to look at anterior coverage, which is extremely important. And many times, you see that people don't get that. Now, Jasmine, this is what I was saying about epiphyseal extension. This is an MRI, and you can see that here. I don't know if you can appreciate it, but see that is extended distal and more lateral. And then that's leading to your cam. So that epiphysis is actually extending down and creating that lesion there. And if you can also appreciate, if you were to put a line through that to your weight-bearing dome too, it might be a little different with regards to the angulation of that physis. So MRI to evaluate for labral pathology, we do utilize it. You can see sometimes it's easy to see if you have a labral tear. So the labrum is the little triangular structure that's on the edge of the acetabulum there. The first two views are our coronals, and the other view there is the axial view. And you can see a little rent there between the acetabulum and the labrum. However, I would say that MRI is really sensitive, and many times it's red as a labral tear, and we go in, we don't see labral tears during the arthroscopy. And so it's a little overly sensitive sometimes. Now, MRI we utilize to address cartilage pathology as well. We can see subchondral cysts on MRI. Again, as we discussed, labral tears. But these are all the things that we're assessing on the MRI. Again, it's not as specific as it is in the knee, certainly not for articular cartilage and labral pathology. Quickly, when we discuss articular cartilage damage, you've heard of the outer bridge. Many of us choose to utilize the ICRS, which is our Cartilage Regeneration and Repair Society classification, and this is the ICRS grading. It's similar to the outer bridge, but suffice to say, one is going to be superficial. 2, you're getting some deeper lesions, and then it breaks down. 3 is obviously the most severe, and we're only going to consider doing any sort of cartilage restorative procedure on something that is a 3 or a 4. That is a full thickness cartilage defect. And then you consider doing a cartilage restorative procedure for that. Any superficial fissuring, you're not really going to. Now, I put this study in here to show that an evaluation of 545 cases, how accurate are we with regards to our chondral analysis with MRI? And this study demonstrated that 30% of patients with full thickness lesions, when you went in and scoped them, full thickness, right down to the subchondral surface, were negative for any chondral pathology on MRI. So not just some cartilage damage, full thickness down to subchondral bone. 30% that were found in arthroscopy were negative for any chondral pathology MRI. So again, we use MRI, but we don't hold ourselves just to the MRI. And I wanted to throw this in there too, because this is why we look also at dysplasia versus impingement, because our lesions on the acetabulum are different if you have dysplasia or if you have impingement. And so if you have that, you have this inside out pattern here. So go back to this, the outside in lesion of impingement, the inside out lesion of dysplasia. So it's because of where the weight bearing forces are here. So dysplasia, you're going to get these cartilage lesions that are more central within the acetabulum. And then this is what they look like. So you're going to have actual cartilage defects inside the acetabulum here. This is the labrum up here. This is the acetabulum down here. This is the femoral head over here. And this is the capsule coming up above us here. You're going to get these lesions that you're going to have cartilage defects inside the acetabulum, right inside here. So it's going to be a different management for that. On these impingement lesions, you get impinge against the labrum, then the labrum delaminates the articular cartilage, the adjacent articular cartilage, and then you get these outside in type of lesions. So the force came from the outside and caused damage to the cartilage going inside. And this is what this is going to look like. So again, this is your labrum right up here. This is the acetabulum, and then this is the chondral lesion here, where that is an outside in type of lesion. So you get that flap right there. So we suspect this, right? We suspect intra-articular pathology. Our examination is leading us towards groin pain, intra-articular pathology. Our imaging is leading us towards that. Then what? Then we get the ultrasound guided intra-articular diagnostic injection. So just lidocaine diagnostic injection. If this relieves their pain, all those provocative maneuvers, so you inject them, you do fader, you do all the impingement testing, and it's relieved their pain. That is another data point that tells us that their pain is intra-articular. We're not doing that necessarily for the knee and the shoulder, but the hip. This is sort of the standard of care right now for hip impingement, as you get that diagnostic injection. Now, quickly, I want to touch on borderline dysplasia. And again, that is when you have roughly, and this is your lateral center edge angle that we talked about, and 18 to 25 degrees is the area in which, but we argue, and this is why I say we get that false profile view to see what their anterior coverage is like, to really try to define who's on this borderline dysplastic realm. And why is that? Because we would still do an arthroscopy, and we do have good outcomes for some patients that are borderline dysplastic. But if they're frankly dysplastic, or if they're borderline dysplastic with a hyperlax component, then those patients may go down the path of an osteotomy, of a periacetabular osteotomy. We're not going to really get into it. I'll just show you pictures of it later at the end, where you cut the acetabulum and you rotate it over to cover the head. So, but borderline dysplasia is that, and you can have all these different combinations of such, and this is all this is showing. You can have CAM with a borderline dysplastic hip. You have CAM without a borderline dysplastic hip. So that's why I said you just don't think of certain terms as definitely meaning that it's all encompassing. So CAM doesn't mean that it just means a CAM morphology of an osseous bump on the femoral head neck junction. That's all it means. You can still have dysplasia and a CAM at the same time. And so now ultrasound, dynamic ultrasound is another way where we try to tease out these patients who have borderline dysplasia. Many times it's a female who has ligamentous laxity or hypermobility, and we want to know where their symptoms are coming from. So ultrasound guided injection, and then we do a dynamic ultrasound. Now, dynamic ultrasound is in its infancy. The group, Boston Children's Hospital, where I came from, where we have a couple studies that are out. We discussed with our group here as well. We're all going to call together about evaluating this, but we're starting to evaluate these things in our dynamic ultrasound. How much is that femoral head translating in relation to the acetabulum, and what does that mean, and does that help inform us? So those are all sort of from a research standpoint, moving forward to help diagnose these things. So version, this is why I think it's helpful a bit to do the foot progression testing and then evaluate this. Normal hip on the left, anteversion is B. So anteversion means that the femoral head and neck is pointing forward, it's pointing anterior more than normal. And then retroversion is pointing posterior more than normal. Does that make sense? So take the foot and you look at the foot that's pointing straight on all of these views, and then look at the femoral neck. So the straight foot view, normal here, straight foot view in B, you see the acetabulum is pointing anterior. The femoral neck and head is anterior, and then retroverted femoral retroversion. If you look at the straight foot view on the C, the femoral head and neck is pointing posterior. So that's version. Yeah, so this was a study that just looked at 538 hips, and they found abnormal torsion or version and present in at least 50% of patients who have hip pain associated with FAI or dysplasia. So significant torsional issues in these patients. This is why I said that the foot progression walking is not always accurate. 77% with increased femoral torsion walk with a normal foot position. So you'd think that increased femoral torsion, they might walk with like a pigeon-toed gait, but they don't necessarily, because they've adapted with their torsion, so that it can fool you. So that's what I'm saying. Just because you see them walking with a normal gait doesn't mean they don't have femoral torsion. It's kind of why I'm putting this up there. All right. And this is how we evaluate it. There's different ways of doing it. There's all these different methods. We're not going to go down the paths of what these methods are. I use the Ray Karras method, but basically I'm going down and drawing an angle right through the center of the femoral neck, and then I'm measuring that, and then you measure off of your posterior condyles. This is why you need a CT scan, and Miriam, we discussed the other day, that includes the entire extremity from the hip through the knee, because this is actually how you calculate version. Or I think I don't know if it was you, I was actually talking with one of the residents actually, sorry. And you need a CT scan that goes through the entire hip and knee, because you get an angle off the posterior femoral condyles, and then you also get an angle off the femoral neck. And so I'm working with our teams here now, our MSK radiologists, to go through this and pick one method, which I like the Ray Karras, because I think it's easier. Pick one method, choose that, and then they should help us inform us of version. So you don't always have to measure it on your own. This is just showing why I choose the Ray Karras. If you measure versions at different levels, your version changes. And so you have increased version if you measure it more distal. So D is Murphy, that's more distal. And you're getting increased version over there. And so I think that you're going down a path where you might be considering doing derotational osteotomies in people maybe a little bit too often. I like the Ray Karras, it's right in the middle, and it's easy. You just do it right through the center of the femoral neck when you see it most prominent. But we're not going to dive into too much of the weeds of this, but that's how you assess version, and there's multiple ways of doing it, and you have different results depending on how you assess that version. But you just got to go with one method, and it's like anything else in what we do. We need to tell people what we've measured version. This is the version we got, but this is the method we used, so they're informed. Acetabular version. This is how we measure that. You draw a straight line through the acetabulum, or you can draw a line across the acetabulum, posterior acetabulum, and then drop another line that's perpendicular to that, and you measure from the anterior and posterior aspects of the acetabulum. This is an axial, view of the pelvis right now. And then that gives us version. And so version of the acetabulum is about 20 degrees anteverted. And if they're less than that, we call it relative retroversion. And then this is another view of the acetabulum. Now, when I get version 2, I don't just do it once. I prefer to do it cranial version and central version. So I know where the version is through the weight-bearing dome, because the weight-bearing dome is going to be the superior aspect. And so I would get 2 points of version analysis of the acetabulum, cranial and central acetabular version. The Kibben index, just briefly, it's both combined version. So you combine what your femoral and your acetabular version is. It gives you your complete total version, and normal is between 30 to 60. McKibben index is very important because we evaluate that, how does version affect our outcomes, and is increased version leads to worse outcomes. And we have studies that suggest that it does, and we have studies that suggest that it doesn't. And so it's under further investigation. Hip arthroscopy. So getting at that, there's a nice pictorial here of hip arthroscopy and what we would do, just to give you a sense. So we go in, you can debride the labrum, you do a labral repair. This is what a labral repair is. You just go in, put anchors in, and you wrap it around the labrum, and you refix the labrum there. A reconstruction, you basically go in and you take down the labrum because there's not enough, or it's calcified, and so there's not enough labral to repair, and you put an allograft or autograft, but typically an allograft labrum all the way around. And that's a labral reconstruction. So these are options here, segmental reconstructions, but just generally speaking, a labral repair here, labral augmentation here, labral reconstruction, here. For arthroscopy, we place the patient supine. This is the post over here. We've gone to postless now. So a lot of tables go postless because we have less complications intraoperatively with a postless system. We have more complications with this, and pudendal nerve complications and such. Femoral head here, this is just defining our different portals that we're going to use, but typically you're going to use what we call an anterolateral portal, which is right here off the anterior aspect of the greater trochanter, and you're coming in along the neck there, and that's your anterolateral portal. You're going to make another medial portal over here, and you're going to make a distal anterolateral portal down here. As we get into the hip, this is the ball or the femoral head, right? This is the labrum that's here. And then this is the acetabulum that's here with the articular cartilage. Down here, you can see that's articular cartilage here, and then you can see is nothing down here. It's like a little darker space. That's the cotyloid fossa. That's what I'm saying. This is your rim of cartilage, not the whole acetabulum is cartilage. It's just this thin rim of cartilage here, and then this is your cotyloid fossa down there. So really, the head is bearing weight against this articular cartilage right here and the labrum. And then this is suggestive of a labral tear right here. Similar, probing, seeing a labral tear underneath the labrum there. This you're looking in. This is the femoral head here. This is the acetabulum with the labrum right here. Now this labrum is like calcified, or it's just not. There's not much labrum there. You can see the capsule up above you here that they've created a separation between the capsule and the labrum. They've prepared the acetabulum back here to put fixation and put anchors in over here. And then they've reconstructed. This is a labral reconstruction. They put a new allograft labrum in here. You can see that right here, and you can see it right here. This is the allograft labrum. This is the femoral head when they took traction off. So this is in traction, so you can work within the space. This is off traction. So you're just getting the relationship of your labor repair there.
Do you take out the calcified labrum or just put the allograft on top of it?
Yeah, it's a great question. So if it's calcified, most people are going to take the entire labrum out. They're going to put a label, they're going to put the allograft there, and it's going to be a labor reconstruction. If there's too little labrum to fix, not enough labrum, right? But it's not calcified, you can do an augmentation. And now we're getting into the weeds of things, but it's still a reconstruction. You're going to put a graft, but you'll leave the remnant labrum there. And you'll tie throw your sutures around the graft and around the remnant labrum. Does that make sense? But if it's calcified, people are just taking the labrum out, preparing the acetabulum, putting the graft in.
Got it.
I'm not going to go into too many details. I mean, ask questions if you like. I love discussing it, but these are just surgical things. But I thought it would be helpful for you to see exactly what's going on, what these procedures are, and what's being done inside the hip. And so this is your femoroplasty. So you have your cam morphology right here, or this is more even like an osteophyte right here in this femoral head neck junction. And this is the cam. You're literally shaving that down, trying to create a nice concavity here. And obviously you're looking at imaging and evaluating on imaging every small, the entire process. Intra-articular, here is what it's like right here. This is the capsule that's all behind you. Some of that red coming in through here could be the iliocapsularis. That's just superficial to the capsule that they've gone through here. But this is your cam morphology. And many times you go in here and it's cartilage that's over the cam. And just so you know, and this cartilage here is viable. And so there's a way in which we can shave this and collect this cartilage and then micronize it and put it back in and as micronized autograft for the patient to address any acetabular lesions. But this is the cam here and what it looks like. And then this is, now you've gone and you've done your femoroplasty. You've made a concavity here. So when it comes up, it doesn't engage that labrum anymore. Does that make sense? Be aware, some people will work and not get the right imaging inside the case, and then you get a huge chunk of this is an over resected cam right here in one region. Can lead to fracturing. So chondral damage in the hip and how to address it. This is why I put this in here. So this is your articular cartilage here. This is the labrum that's above here, but we're basically focused on this. Why? Because this is your subchondral plate right here. So this is a full thickness cartilage defect. This is subchondral drilling. You're going to put a curved guide in here and you're going to drill. This is microfracture, right? Subchondral, it's less invasive microfracture. So you drill, and then you're looking for bone marrow elements here. Then you're looking for fibrocartilage to fill in the defect here in the acetabulum. So this is one way to address some of your acetabular chondral damage that you have. Another way is through cartilage restoration. So biocartilage is a proprietary product that is extracellular matrix, and it's allograft. So you do some subchondral drilling here. This is your defect. This is your articular cartilage. This down here is your colloid fossa. So there's no cartilage there, but that's normally no cartilage there. You do some subchondral drilling, then you place this biocartilage allograft in here, and it sits over, and you put fibrin glue over the top. And so this is your labral repair. See a suture right in through here. It's your labral repair. And this is your biocartilage allograft right in here. You guys want to see a quick video, or are we running out of time?
Let's watch it.
So I thought this was a good one, and it's 11 minutes.
Driving a
Watch the
hip
whole thing. I'll
arthroscopy
fast forward.
along with some traction to provide necessary space.
So this is the typical setup that you're going to have here. We use different tables, but this is typically this is a postless setup that they have. He's just marking out his portals that he's going to use. Everybody marks it differently, but we all use pretty much the similar portals. He's placing his cannulas. I can fast forward here. So he made his first anterolateral portal, and now he's in with his arthroscope. Femoral head is to the right. This is the cartilage there. This is the cartilage here. This is the cotyloid fossa down here. You can see no cartilage, and this is labrum, and then there's the capsule above us here. Okay, his next portal is going to come in right in through here. There it is. So there's the needle making the next portal, and you got to be careful. You see how tight the space is, right? So you don't have any, you don't hit the head, you don't get into the labrum, and so Now you're dilating that and creating the other portal. So you're right in between your head, you're right in between the labrum, and you're setting up your other portal, which is the mid-anterior portal typically. Now you use a knife and you make a capsulotomy. So you cut the capsule. So that's what they're doing here, cutting the capsule. So labrum here, cartilage here from the acetabulum. This is the capsule. So see, Miriam, it's right next to it, but they're different structures. But after you repair this and do a surgery on it, you can appreciate that you might get adhesions between this capsule and this labrum, and that can be problematic. Which is why many of us now are using losartan post-op, because it has antifibrotic properties, and you're seeing that you have decreased issues of capsular adhesions. A lot of research coming out of previously Pittsburgh with a basic science guy who used to work with Mark Philippon at Pittsburgh, but now they're at Vail, and they're really leading the losartan research. So now this is looking from a different aspect. They're basically doing a capsulotomy again. And why do we do this? So we can see. We're opening up so we can see and we can work. Now he's probing the labrum. This is the entire labrum right here. This is about 12 o'clock here. See the cartilage fossa? No cartilage down there. Here's your cartilage rim. Now this is anterior, and that's your psoas U would have been over there. This is where your ligamentum teres is. So there's a lot of good progenitor cells in that fat pad right there, similar to the fat pad of the knee. And he's looking at the posterior labrum right now and back around, and using a 70-degree scope, so you can see quite a bit by just moving the eye around in a 70-degree scope. So now this is the same area. Now you're preparing the acetabulum. So you're preparing the acetabulum right here. This is the capsule back here behind you. See if I can get it better. He changed his view here. So he changed his view. This is the capsule back here, and this is the acetabulum. He's preparing the acetabulum. So you can see it's separate. But you got to separate it from the labrum so you can prepare.
But you're in the capsule in that view.
You're in the joint.
It's not behind you in your pericapsule. You're that view. He was.
So right here, you're in the joint. You're in the joint. This is the acetabulum. You're intra-articular. This is labrum right here. This is the capsule up here. And so you're basically, sometimes you put some sutures in the capsule, suspension sutures, when we pull it up to give it a little bit of traction. And so then it helps us form it helps us get underneath the capsule and be able to prepare this acetabulum. But yeah, this all intra-articular work. We're on the deep capsule right now. Superficial to this capsule is iliocapsularis and gluteus minimus sitting right superficial to this capsule. Which when you do a capsulotomy, you can see it. And so why is he doing this? Why is he preparing that? Because that's where you put your anchors. You put your suture anchors in right there. Probing the labrum again. So this is prepared acetabulum, capsule up here, labrum down here. And now he's going to put his suture anchors right along this rim of acetabulum. See? So suture anchor was drilled and then placed. And then now he's taking the suture and he's going to pass it around the labrum. And now he's tying knots. Now this muscle up here, you kind of see, because you already did a capsulotomy there. That's probably iliocapsularis, because that's anterior. So iliocapsularis is literally right on that capsule, adheres to the capsule, and then posterior you get minimus, gluteus minimus. And then see, place another anchor, pass the suture through. Now he's placing knots down. I do knotless. Many of us do knotless now, but it's just technical details. But this is how we all typically do it here, with placing anchors and tying the suture around the labrum. And this is how you do it too. This drilling into the acetabulum. You can see he's making sure he's not drilling into the cartilage there. And then he's going to place another anchor down. And capsule behind, right? All capsule being preserved because you want to repair that capsule after. And then he's tying down his labrum here, and you can see that's the articular cartilage down there. You want to make sure he didn't go through it. And now he's going to pass through the labrum. Taking care not to damage that cartilage in the acetabulum. So again, technical details, we'll discuss amongst ourselves all the time, but this is how it's done. And the head's right here. So you can see that's a tight space, especially compared to the knee. tying his sutures, and then here he's coming down. This is his repaired labrum. And getting more anterior here. It's kind of like the iliopsoas U right in through there. It's anterior. And you can see the pathology is usually in that anterior region. It maybe comes back posterior slightly, but usually in this anterior interlateral lesion. Traction's coming off, so now the head's coming down and it's pressing up against the acetabulum. Now you're getting that seal, and he's now testing to see what his repair looks like. And this is capsule up here. Now you go back and now you're in the peripheral compartment, right? So central compartment is it's all intra-articular, we're all underneath the capsule. But central compartments in the acetabulum, this is peripheral compartment, is to address the cam. So now this is the cam. He's preparing this for the cam. There's always some cartilage over the top, so he's preparing this, and then he's going to go ahead and shave the cam. So this is what the cam work is like. This is the labrum right here. This is the capsule. This is your capsulotomy. That's why that's open right there. Now he's burying away the cam. Different views, burying that cam lesion. And now he's testing it, and you can see the cam hopefully doesn't engage the labrum anymore. See, created that concavity. I hope that helps with the visualization. Now repairing the capsule. So that red back there, that is your iliocapsularis or your minimus, but I think that's iliocapsularis, it's anterior. Now this is repairing the capsule, throwing sutures through the capsule to pull the capsule back together and repair it. If you don't do this, then patients will have some instability after. The capsule is stout, it's thick, you got to repair the capsule back after. Historically, they didn't always do that, but now everybody's repairing the capsule. Unless it's like a older male patient that was tight in, but typically you're repairing all these capsules, and this is what it is right here. So you can get appreciation. This is the capsule. You're taking both those. That's a distal leaf of the capsule that he's in right now. And then the other one's he's grabbing the suture that's through the proximal capsule. And he's pulling the distal and proximal capsule back together because he created that capsulotomy with his knife, if you remember in the beginning. And so that capsule is now going to close over the top of everything that he did. And that's it. So I can go back to this. This is my post-op protocol. We can go through it in more depth, but basically, this is my post-surgical protocol for just care and anticoagulation, things like that. Do 81 milligrams for a month, but crutches for about 2 weeks on crutches, protected weight bearing. Especially if you do the femoroplasty, and then you get into light jogging by about 3 months, and then really return to activities in 5 to 6 months.
Can you share that with us? Can we have send it in the email?
Yeah. And go through it. And then this is just 2 slides on PAOs. So if you have dysplasia and there's too dysplastic to be fixed with an arthroscopy, then this is still a hip preservation procedure. It's just an open hip preservation procedure. And so you do an osteotomy right here of the acetabulum. So you cut along all these different cuts here, the ramus, you cut the ischium, and you cut along the ilium here. You rotate that fragment to create more coverage, and you place some screws. You fix it with screws. That's a PAO, and this is what it looks like here. So on the right, it's undercovered, dysplastic. They've cut the ramus, the ischium, the ilium, and along the quadrilateral plate. They've rotated and created more coverage, and then placed screws. So this is the answer for dysplastic hips. This is the hip preserving answer for dysplastic hips, pre-arthritic dysplastic hips.